Okay, I'd like to thank SPAEN and the Raft group, the other organizations who's organizing the meeting, for inviting me to discuss what I would consider some of the latest advances for patients with GI stromal tumor. And I'm going to show you today more or less the way I think of GIST. Not everybody approaches the management of GIST patients in the same way, but this represents our approach at Sylvester. So first of all, GIST is the most common GI sarcoma. In fact, it may be the most common sarcoma. 0.2% of all GI tumors, but 80% of sarcomas that arise within the GI tract. Unfortunately, there's a high propensity for metastatic disease. Importantly, and this may be the best example in all solid tumors, is that gene mutations drive the phenotype and determine the therapy. Metastatic disease, and of course, primary tumors in certain settings are treated with tyrosine kinase inhibitors. And the most active are imatinib, sunitinib, and regorafenib. And we use a number called PFS that gives us an indicator of how long those medicines tend to work for. So for imatinib, it's about 2 years. For sunitinib, about half a year and this is a median or basically an average. Certainly many patients do well, we know, for much longer in regorafenib. The newer agents that we'll be discussing today are ripretinib and avapritinib, which also have some activity, as you can see with the PFS numbers that we use to assess how active they are. Importantly, avapritinib is very active in PDGFR mutated GIST. In fact, the median PFS at the time of this presentation today has not even been reported. So it'll probably also be in the 24-month range or longer. Now, I mentioned that GIST is a molecular disease, and these are some of the mutations that we see regularly in patients who have GIST. By far, the most common mutation is in a gene called KIT. In a region, exon just means region, in a region called exon 11. The most second common region where there's mutations is in exon 9 in the KIT gene. KIT resistance mutations, meaning after a patient's been on imatinib for that 24 months on average and the tumors start growing again, resistance mutations occur. And the two most common sites for resistance are exon 13 and exon 17. So that KIT gene retains the original mutation, for instance, exon 11, but a new mutation emerges. And this is actually a new type of cell that existed before in small numbers, but under the selective pressure of imatinib, which killed all of the tumor cells without exon 13 or 17 resistance mutations. Over time, these resistance mutations emerge as the dominant clone. PDGF receptor D842V is also one of the types of GIST that we see. And then there are some other types such as Sdh deficiency. Sdh is a protein that's important for tumor cell function and gene regulation, and the loss of Sdh in a cell in the GI tract can turn that cell into a GIST cell. Other mutations include Raft, NF1, PI3 kinase, IGF-1 receptor, and a newer reported mutation called TRK, TRK fusion. In other words, one gene gets paired with another gene that it's not supposed to be next to. And when that happens, just like with all of these mutations, when that happens, a normal cell turns into a cancer cell. So these mutations are called driver mutations because they have the capability to drive a tumor. In other words, turning a normal cell into a cancer cell. Importantly, over the last many years, we've been able to not only detect these mutations in patients with GIST, but we've been able to identify treatments for patients with these types of mutations. And this is critical paradigm to treatment for GIST patients. And this doesn't, this is I think GIST is the example where the whole world of oncology has learned how to do this. And that is, if a patient has a certain type of mutation, you use a certain type of medicine. Or for instance, KIT exon 9, we use a higher dose of imatinib. PDGFR, we use Avapritinib. For Sdh deficiency, we might try sunitinib, regorafenib, or I'd like to point out a temozolomide clinical trial that by Jason Siklik from UCSD that we have open now at Sylvester Comprehensive Cancer Center. A Raft mutated GIST, we use a Raft inhibitor. If a patient has a Raft mutated GIST, you wouldn't want to treat them with imatinib because it wouldn't be effective. Imatinib doesn't inhibit the Raft inhibitor. However, imatinib is very effective at KIT, and Raft inhibitors like vemurafenib are very potent at inhibiting Raft. Similarly, I'll give you an example of TRK fusion. Imatinib, none of these other agents have any activity. If you have a patient with a TRK fusion GIST and you treat them with any of these agents, it's not going to help them. They're only going to get side effects. But if you use entrectinib or larotrectinib or other TRK inhibitor, it's going to be very effective. And then there's some emerging evidence that exon 13 mutated GIST should be treated with sunitinib, and exon 17 mutated GIST with regorafenib, ripretinib, or even potentially avapritinib. Now, again, this is a paradigm that we've developed at Sylvester in our approach and may not apply to every, certainly wouldn't apply to every oncologist in the world. Now, importantly, we did a study last year in the United States looking at mutation testing. And this is from a huge database, the National Cancer Database in the United States. And this was over 4,000 patients. In 4,000 patients, we found that only about 30% of the time in this time frame from 2010 to 2015, only about 30% of GIST patients underwent KIT mutation testing. That means 70% of the time, physicians in the United States are treating GIST patients blindly. As you saw on the previous slide, it doesn't make any sense to approach a patient that way. You need to know what the mutation is in order to determine the appropriate therapy. But unfortunately, in the United States, only KIT mutation testing is only performed about 30% of the time, which was a very disappointing finding for us. The other finding from this study was that Black Americans even had lower mutation testing. There's a huge disparity and opportunity for education in the community for the importance of mutation testing. Now, how do we do mutation testing? Mutation testing can be performed on tumors that were resected from a patient 2 weeks ago, 10 years ago. These tumor tissues are stored in paraffin, in pathology, and can be brought out, have DNA extracted, and do the mutation testing so that you know what type of GIST a patient has. Well, there's a newer technology that allows us to determine what type of mutation the patient's GIST has, but even the whole landscape of mutations in different nodules by assessing the DNA in the blood. As it turns out, and as you can see in this cartoon, tumor cells, this is a tumor cells, as a tumor grows, some tumor cells die. More live than die, so the tumor grows, but they release their DNA into the blood in a process, into the blood, and once the DNA is in the blood, it's called circulating tumor DNA. Well, there's tumor cells in the blood, there's normal DNA in the blood, there's RNA in the blood. So there's a lot of this going on in the blood that we are using technology now to detect. But we're most advanced with the circulating tumor DNA, because that's the DNA from the tumor cell that harbors these mutations we've been talking about. So we can actually collect blood from a patient, we can extract the DNA, we can do mutation testing, and we can identify what type of mutation is in the patient's gist without subjecting them to a biopsy or a surgery. And this is important not only for initial diagnosis, but as you'll see, we are using it in real time to determine optimal therapy for patients who become resistant to imatinib. So Junaid Arshad, who was one of our fellows, published this series last year in JCO Precision Oncology. And what he found was that primary mutations were most commonly exon 11 when we applied circulating tumor DNA technology. The other most common type, not like we said earlier, was KIT exon 9. And then we detected PDGFR. There's been some controversy as to whether one could detect PDGFR mutations in circulating tumor DNA, but I can reassure you we do. And then other KIT mutations such as 13, 17, et cetera. But with this technology, 34% of the time, we didn't really detect a patient's driver mutation. So the technology is something we're still learning how to apply. If we looked at patients with, so that means this technology only detected the driver mutation about 2/3 of the time. But if we apply criteria such as large tumors, mutation, large tumors, progressive on therapy, then we can detect circulating tumor DNA virtually 100% of the time. So patients who have had surgery and don't have a detectable gist, we're not able to detect the DNA. Patients who have very, very small indolent tumors, sometimes we can't detect the DNA. But then we asked the important question about resistance mutations. So when we looked at the patients who we could detect resistance mutations, and that was in 106 patients in this study, we found that 57% of the time they were in KIT exon 17, and 34% of the time in exon 13, and about 9% of the time in a different location. So it is detectable. Resistance mutations are detectable as a proof of principle in this study. Now, what do we do with the information that we receive from resistance mutations? Remember, patients that develop KIT mutated GIST have most commonly mutations in exon 11 and exon 9, and they're sensitive to all of these medicines. Sensitive means green. Green means that the medicine over here in the left column is effective at preventing the growth or even shrinking and killing GIST cells that have a primary exon 11 or an exon 9 mutation. So they're active in all of these primary mutations, all of these agents over here to the left. Now, when you start talking about resistance mutations, it gets a little interesting because there is a separation in activity. And so if a patient's on imatinib for 5, 10 years, who knows how long, and the tumor starts growing again, at that point in time, we would do circulating tumor DNA. And we would usually find either exon 13 or exon 17, 13, 14, 17, 18. And if the patient's on imatinib, it's not surprising that those resistance mutations are resistant to imatinib. Red is resistant. Red is resistant. Now, if the mutation is exon in 13, 14 region, that's a region, then sunitinib is very effective. However, if the mutation is in this region, sunitinib is not so effective. It doesn't work so well. On the other hand, All of these agents down here below sunitinib have activity in exon 17, 18, but less activity at exon 13, 14. In fact, some of them don't really work very well at exon 13 at all. For instance, Avapritinib, Ponatinib, Regorafenib. On the other hand, agents like Ripretinib probably has some activity against exon 13, 14, 17, and 18, but we don't really know all of the details because Ripretinib is so new. We're not exactly sure whether it's better than sunitinib or not at exon 13 resistant mutations. We do hope that subsequent studies that are ongoing will help us answer this question. So now we'll get into some of the newer agents and how they're being used. I just wanted to provide some of the background on our approach to GIST before we get started. And so this is the Invictus study, and it's a medicine called Ripretinib, and patients were randomized 2-to-1. In other words, for every 2 patients that received Ripretinib, 1 patient received a placebo, 80 and 40. Patients were followed until disease progression. And then at the time of disease progression, if they were unblinded, if they were on Ripretinib, they could dose escalate, they could continue on the same dose, or they could discontinue. If they were on placebo, they could cross over to Ripretinib or discontinue until disease progression. At which point in time, they could also dose escalate. So what did the patients look like on this study? Remember, there were 2 Ripretinib patients for every placebo patient, roughly. And when you compare these 2 groups, you want to make sure that they're comparable because we're going to be looking and comparing their outcomes. So it looks like the median age is fairly similar, and that there's a fairly similar distribution between men and women, 55%, 59%. And largely a white population, which is a critique for many studies in the United States and in the world. Equal performance status, fairly similar in terms of anatomic location, size of tumor, and fairly similar in distribution of mutations. So this is that number that we look at, PFS. It gives us a determination and allows us to statistically determine whether one medicine is better than another medicine, or one medicine is better than placebo. And so the median PFS for Ripretinib is 6.3 months compared to 1 month for placebo. So it's not too surprising that Ripretinib is statistically better than a placebo. Probably not too surprising of a conclusion for anybody in this Zoom presentation right now. And this graph just shows the wide difference between the drugs. And we look at the PFS, that's the 50% point, and it took 6.3 months to cross that point with Ripretinib, which means it worked for a long time, and it's still some patients are on it, still some patients are doing well. So it's clearly superior to placebo, and that led to FDA approval in the United States for Ripretinib. Now, another way we look at the activity of a new agent is to look at whether the tumor shrank or not. If the tumor shrinks, gets smaller, then we call that a response. There were no complete responses in either arm, but almost 10% of the patients had a partial response, meaning some degree of shrinkage, and a lot of patients had stability, so that about half of the patients had stable disease for more than 12 weeks. And so this is another sign of activity when you compare it to a placebo. You don't see any tumor shrinkage in the patients that were randomized to placebo. Again, not too surprising to anybody in this room. Now, if you look at these patients here, these 8 patients were patients who had long-term responses. These were the patients that had substantial shrinkage of the tumor. Partial response means 30% shrinkage. So of these patients that had this degree of shrinkage, they did really well for a long period of time. Only one of the patients had disease progression. So that tells us not only do 10% of the patients approximately have substantial regression of tumor, but they also have regression of the tumor that continues for a fairly long amount of time. Now, what about side effects? Let's talk about side effects for ripretinib compared to placebo. It always, you always have to remember that patients do have symptoms. Even when they're on a placebo, they have some symptoms, which can be placebo effect, but can also be due to their GIST. So 14% of the patients on placebo had fatigue. Well, having a cancer can be fatiguing. So that's, again, not too surprising, but you have to consider that 24% of the patients had grade 1-2 fatigue on ripretinib. So you have to consider that about 14% of patients have fatigue because of their GIST, but about 10% approximately probably had fatigue related to their ripretinib. Severe fatigue, meaning debilitating, can't perform your daily activities, only 2%. One of the more surprising side effects for ripretinib was half of the patients had hair loss. So alopecia or hair loss is a common side effect that's seen with ripretinib to a much higher degree than we see with other TKIs. And in fact, placebo didn't see any. The other side effect, nausea, myalgia, were all grade 1-2. And grade 1-2 means that it's a side effect, but you can still do the things that you need to do in your life, that you're functioning, that you have a reasonably good quality of life. Grade 4 side effects are the severe ones that mean you're spending more than half of the day in bed and can't really function. And those, thank goodness, are very rare with this agent and others. And then there's some laboratory abnormalities that we keep an eye out for also. So in conclusion, ripretinib is fourth-line agent that we use for advanced GIST patients, improves outcomes compared to placebo. And I think this is just a philosophical opinion of mine that perhaps we're done, and hopefully we're done doing placebo trials in patients with GIST. Let's move on to the Navigator study. Navigator is an open label study of Avapritinib. So this is a different agent, Avapritinib, and this is a phase 1 study. And the objective of the phase 1 study is to determine the phase 2 dose. Once we determine the phase 2 dose in a phase 1 study, we typically do an expansion where we can see how patients do in specific subsets. So these are just patients that had prior, at least 2 lines of prior therapy, had a mutation in KIT or PDGFR, were treated with Avapritinib, 300 milligrams daily. And we looked at the phase 2 expansion cohort and looked at 2 cohorts, 4th-line GIST and PDGF receptor. So these are the patient characteristics between the 2 groups. Again, fairly similar, although we're not comparing these 2 groups directly, but the 2 groups are similar to what we've seen in other studies. The side effects of Avapritinib are a little different. There's no alopecia or very little alopecia reported. However, there is some nausea, some more fatigue, importantly anemia. Patients treated with Avapritinib have a higher probability of developing anemia that needs to be treated in some way. Now let's discuss the PDGFR alpha mutated GIST patients. So these are exon 18 mutated patients treated with 300 or 400. And what you'll see on the curve at the left, it's called a waterfall plot because you see these downward bars. Well, each downward bar represents a decrease in size of the tumor. So the first dashed line is the cutoff for the definition of partial response. So so patients with PDGFR D8 exon 18 mutated GIST, almost all of them had some decrease in size of the tumor, as you can see, because these bars are going down. The two patients here have bars going up because their tumors grew on therapy, which is very rare in this situation. The 95% of the patients in the study with PDGFR exon 18 mutation had tumor shrinkage. In fact, the partial response rate at the time of this report was 34%, but now we know it's much higher. It's in the 34 patients. Now we know it's in the 86% range, meaning that 86% of patients are going to have substantial shrinkage of the tumor, which is very effective therapy for these patients who some of whom didn't have treatment previously. And these are the duration of responses. Again, those patients who do get shrinkage of tumor, it's highly, highly, highly durable. This is out almost to 2 years. And the majority of patients have tumors that are still shrinking or not growing. Now, Avapritinib in the KIT mutated patients, 4th line or greater, also had activity. Again, this is a waterfall plot. So you can see that the majority of patients, more than 50%, had some shrinkage of tumor, but some patients did have growth of tumor. 22% of the patients met this cutoff that we consider an objective response rate. So Avapritinib is clearly active in KIT mutated GIST as well. And those patients had durable responses as well. When you follow the patient who met the criteria for response, could be durable for many, many months, even over a year. So in conclusion, Avapritinib is remarkable, has really remarkable game-changing activity at D842V and other exon 18 mutations in PDGFR. It also has some activity in KIT mutated patients, undeniably, as you can see on this data. Now I'll show you a couple of examples of where we're going with this. This is a 55-year-old man with a gastric KIT exon 11 mutated GIST. You can see in the first panel at the left, this is the patient's right, this is the patient's left. The arrow is pointing to tumor nodules. The patient had KIT exon 11 mutation. We did circulating tumor DNA and found that there was a KIT exon 17 mutation, resistance mutation. At that point in time, one of the newer drugs approved for leukemia was ponatinib, and this was a few years ago, but ponatinib was found to target KIT exon 17 resistance mutations in vitro studies by Mike Heinrich. And so we decided to try it. Took a lot of work. We were able to get it off label or from the pharmaceutical company to try in a single patient. And you can see now, looking at the arrows, these tumor nodules are substantially smaller. And even after 12 months, even smaller still. So this would meet the criteria for a partial response. So this is active. And meet the criteria for partial response. And it was based on knowing what type of resistance mutation the patient has. Here's another patient. This is a 52-year-old woman with a small intestine GIST, KIT exon 11 mutation. And you can see a tumor nodule here at baseline. In this patient, this was a few years ago, we had just started doing circulating tumor DNA. The patient progressed on imatinib, was placed on regorafenib, and had rapid progression. Then we got the circulating tumor DNA results back. You can see how large this small tumor got, very large in a short period of time. We got the circulating tumor DNA back, and the patient had exon 13 resistance mutation. Well, exon 13, if you remember from the table, exon 13 for regorafenib is red. Regorafenib is not effective at exon 13 resistance mutations. On the other hand, sunitinib is. So we switched the patient immediately in the hospital from regorafenib to sunitinib, and she's had a great response that's been durable for some time. So primary and resistance mutations should be determined in order to provide optimal therapy. ctDNA is a rapid, non-invasive tool. Avapritinib and Ripretinib are new active agents for GIST patients and could be used. I think a number of questions remain. Can these be used in earlier lines of therapy? Is there a role for Ripretinib in second-line therapy? Well, that clinical trial is ongoing. Ripretinib versus sunitinib, we should know the results this summer, hopefully, as to whether Ripretinib could be better than sunitinib after imatinib quits working in patients. Can we move it up to frontline therapy if it's that active? And then we also have to ask whether these new active agents, such as Avapritinib and Ripretinib, we know that they're extremely active in certain populations. Could we use those in neoadjuvant or adjuvant setting? And then what about combinations? We saw that there are two types of resistance mutations, exon 13 and exon 17, and that you have to use one drug for 13 and one drug for 17. What if we had one drug that could cover both resistance mutations very effectively? And what if we had a combination, a sunitinib plus, for instance, PLX 9486? I didn't talk about much today, but that's been reported as well. That combination has been reported to be very active as well. And we're hoping for clinical trials to assess new KIT inhibitors as well as combination therapies in this population. Well, I'd like to thank the GIST team back at Sylvester, my medical oncology colleagues, Gina D'Amato, Emily Johnzak, and our pediatric sarcoma expert, Dee Deer. Managing GIST patients or sarcoma patients is really not possible without really good pathologists, and we're lucky to work with Andrew Rosenberg, Liz Montgomery, and others. Assessing response through radiology is critical. You have to have reliable radiologists, and as a medical oncologist, I would be incomplete without the expertise of our sarcoma team, nurses, nurse practitioners, and everybody else you see on this team. It really takes a group effort in this complicated world of GIST and other sarcomas. So I'd like to thank everybody for your time and attention today. I'd be happy to answer any questions. You can also find me by email or on Twitter. So thank you very much.